Okay, thank you so much, and welcome to the APA's American Psychiatric Association's monthly lifestyle psychiatry webinars. I'm very excited. I'm Gia Merlot. I'm the chair of this caucus for the American Psychiatric Association, and it's my pleasure today to introduce you to Dr. Urvi Shah. She is a physician with an MS and is an assistant attending at the myeloma service at Memorial Sloan Kettering Cancer Center. She is board certified in internal medicine, hematology, and medical oncology, and received her Master's of Science degree in clinical and translational cancer research. Her research interest includes modifiable risk factors like diet, metabolism, and microbiome in cancer. She completed her first pilot nutrition trial in plasma cell disorders to date and has 3 other dietary trials enrolling. She has been supported by Cancer Development Awards with the NCI, K-12, International Myeloma Society, and the American Society of Hematology, and research awards, Young Investor Translation Research, etc. She has published papers in prominent journals and has been an invited speaker and chair for multiple sessions nationally and internationally. And I am so proud to say that I actually wrote a paper with her as well. So that came up in JANMA about a totally unrelated topic we could talk about if anyone's interested. But Dr. Shah, thank you so much for joining us.
I actually added a slide about it at the end.
Oh, nice. Oh, good.
Let me try to share my screen.
Beautiful. So I don't know how long you're going to be talking, Urvi, but if you can do 45 minutes, and then that'll give enough time for question and answers, that would be amazing.
Yeah.
Yeah.
Sorry. Do you see the slides?
Not yet.
No.
We had them a minute ago.
Yeah, I'm going to share it again. I don't know what happened. Do you see them now?
Yes, we're good.
Okay, great. So thank you for this invitation, Gia, and thank you all for spending this evening listening to me. I know that this may be a topic slightly different from what you practice in general, and I would be happy if there are things that don't make sense, please stop me and we can discuss. Hopefully the things I talk about are principles of good health and just seeing how this helps patients. And we've had some success where a patient, who was on antidepressants came off also on one of our trials. So I do think that there is a connection with mental health and lifestyle, and that's why you have this seminar series, which is awesome. So these are my disclosures. I just wanted to bring up an example of patients we see in the clinic and probably what you see as well. But these patients often have multiple medical problems, and that affects the ability for us to give them the best kind of treatment, such as a transplant, CAR T-cell therapies, or even trials. And so they will live a shorter life because of that. Of course, if we could avoid many of the things in green, which I think are modifiable risk factors that could be prevented, then that is possible to actually be able to give them therapy. So even if it doesn't directly impact cancer, many of the things we do indirectly, it's going to affect the ability to get treatments. And simultaneously, when we take care of patients many times, this patient doesn't look very sick. If you see, the vast medical history is not really much, but this patient died in remission of a cardiac arrest. So sometimes when we do cancer therapies too, we have increased or worsening of comorbidities or the cardiotoxicity risks as well, suggesting why I think this is so important. What food or supplements can I take? I think in cancer especially, but I'm sure all of you experience this too, is a most likely question to be asked and the least likely to be answered. And so I think that this research and infrastructure to support patients is really an unmet need. When you look at patient perspective, and this was a patient who messaged me on social media and said, my very respectable oncologist team answered, just keep eating a balanced diet. And I realized that ultimately it was my responsibility or a personal responsibility. And I've seen oncologists say, just eat a healthy, balanced diet to cancer patients and say that's enough. We don't need to tell them anything more. But I think the challenge is like, what is a balanced diet and who really follows it? And when you look at the US like cancer survivors in this paper, only 12% were getting enough fruit and vegetables. And we do know from other surveys that less than 5% of the US population gets enough dietary fiber. So we're really in a state of fiber deficiency as a whole, as a population. When patients get a diagnosis of cancer or pre-cancer, we wanted to see whether they make dietary changes or have questions about this. So we surveyed over 400 patients, and these are patients with plasma cell disorders. So they could have what we call the pre-cancer states or cancer. And what we saw is that most of them had questions. Most said their oncologist did not address it. And most, if their oncologist addressed it, attempted to follow this. And what was more interesting was that when we asked them, what were you doing before your diagnosis and after, they said that they started eating healthier foods. Of course, this is self-reported, but it is encouraging to see that patients are making changes on their own, whether we tell them or not. And so you may have heard of the World Cancer Research Fund guidelines or the American Institute of Cancer Research guidelines, and 6 out of these 10 are related to diet for cancer prevention. However, very few cancer patients really even know about them. And in our survey, only a third actually mentioned they were aware of these guidelines. And that is even lower. I think it would be even lower in the general population because the participants surveyed obviously had a bias to respond to such a survey. You can see that when we think about dietary patterns and cancer risk, there's a lot of epidemiologic data, meaning population studies that have looked at this. So one of them is done was the EPIC Oxford, then in the US, Adventist Health, and then in France too, the Nutrinet Santé. And what you can see is all of them showed about a 15 to 20% lower risk of cancer in those who are eating more plant foods than not, and they've analyzed it in different ways. We also know that obesity is a clear risk factor for 13 different cancers, and myeloma, which is the one that I specialize in, is one of those 13. And obesity is linked to myeloma or cancer through multiple mechanisms. So inflammation, insulin resistance, adiponectin, leptin, and then even hormones. And then the fat cells in the bone marrow that directly interact with the cancer cells or the immune cells. Another thing we know is in these pre-cancer states, like MGUS, which affects actually a large population, more than 3% of people over the age of 50 would have it if they were tested. You can see that the risk of progression is double if they are obese compared to if they are normal weight. So could it be that if we help patients lose weight, we lower the risk of progression? And if one study wasn't enough, there's another one also showing pretty much the same risk of progression when the BMI is elevated. We did a study looking at survival with weight at baseline, and we did see that patients who were extremely underweight or severely obese had a slight worse survival, both in progression-free and overall survival, suggesting again that if we can help patients maintain normal body weight, that could be helpful even in treatment and managing it. When we look at diabetes, so we talked about obesity being a risk factor for cancer, and I think most of you probably are aware of that, but diabetes is one that we don't think about as typically, or think about it as a risk factor for cancer too. And it is a risk factor for heme malignancies as well, mainly pancreatic cancer most commonly, but also others. And in this study, you can see that they showed that metformin use was associated with a reduced risk of progression from the pre-cancer to cancer, and the GLP drugs were also associated with a reduced risk. With diabetes and risk of cancer, I think you can think of it in two ways. Is it a correlation issue where things that cause diabetes also cause cancer, and that's why we're just seeing more of them together? Or is this truly a causation issue where the things that cause diabetes lead to high sugar, high insulin, which then drives cancer risk? I think the answer is probably somewhere in the middle, and I think both factors probably play a role. I really like this study, which looked at type 1 diabetics, and it looked at insulin dose and tried to see does insulin dose affect risk of cancer? And what you can see is that those who had the highest insulin dose actually had a lower cancer-free survival or probability, suggesting that they're at higher risk of cancer compared to the lower dose, suggesting a dose-dependent effect of insulin on cancer risk. When we analyze data in myeloma patients, again, looking at who has more diabetes, we do see that Black individuals are twice as likely compared to white to have diabetes, but also diabetes leads to worse survival. In mouse models too, we show that mice with diabetes and myeloma progress much faster than mice without diabetes, suggesting improving control, potentially reversing diabetes with lifestyle changes may be really beneficial to outcomes. Another concept, the microbiome, I'm sure you are all very much familiar with it, but we are more microbiome cells than human cells, suggesting why it is so important in health and disease, and even through gut health, systemic symptoms or health is also very much tightly linked. And so it's quite important to feed the microbiome and think about what foods are important for that. And usually fiber is one of the main foods. Thinking about, can progression be progression of a pre-cancer to cancer actually be driven by the microbiome itself and not thinking about other factors? This study actually looked in mice, and it was showed mechanisms of how that could happen. So they had mice from the same kind of mice housed in Italy and in the US. And up to 2015, the mice were progressing to cancer from the pre-cancer at a similar rate. But then after 2015, something happened, and then the mice in the US were progressing much faster than those in Italy. So they thought there's some environmental effect that's leading these mice progressing faster. So they looked at the microbiome and saw significant differences, especially in this one bacteria. So what they did is then experiments in mice. One is that they gave antibiotics to the mice to get rid of the microbiome and see if that can delay progression, which they showed. But then they also looked at these specific bugs, and the heparinolytica, which is in red, actually was associated with worse survival, whereas the melanogenica, which is a good bacteria, was associated with better survival, suggesting just microbiome changes could affect outcomes. And then they looked at IL-17, so it's a cytokine around inflammation, and they showed that high IL-17 is associated with faster progression than IL-17 knockout mice, suggesting again that inflammation and cytokines may drive progression. They also showed that the smoldering myeloma or pre-cancer state have higher levels of interleukin-17 than healthy individuals, and those that progressed within 3 years actually had higher levels than those that progressed in greater than 3 years. And so they felt like the gut microbiome is inducing these type of white blood cell called T helper 17. These cells are migrating to the bone marrow from the gut. And in the bone marrow, they are producing the cytokine IL-17. And then that IL-17 is favoring progression of the cancer. So very clearly showing a microbiome immune cancer progression connection. You may all have seen this study, and if you haven't, this is in healthy individuals. And this was a study which looked at 18 participants. They gave them 20 grams of dietary fiber added to their baseline for 4 weeks, and then looked at what happens to the microbiome. They saw an increase in microbiome function, such as cazymes. Cazymes are carbohydrate active enzymes, which basically digest fiber or carbohydrates that a person eats. So if a person is eating a fiber-rich diet, they're probably going to have more of these enzymes, and also short-chain fatty acids such as butyrate, acetate, propionate. They looked at participants who to add 6 servings of fermented food for 4 weeks and showed that microbiome diversity improved and inflammation went down. So again, fermented foods can also impact the immune system very directly. And to add to that data, there was another study in healthy individuals. I'm not sure if you've heard of this study, but this was done at the NIH, and it's a metabolic chamber study. And in this study, participants were put either on 2 weeks of a low-fat vegan diet or 2 weeks of a low-carb ketogenic diet, and they were admitted for the whole period of the study. So basically, all the food that they were eating was being given by the study. And it's the most controlled kind of study if a patient's admitted to a metabolic chamber for a dietary study. So it really gives us good insight into really what's happening. And in this study, they did see that the low carb diet lost a bit more weight than the low fat diet. But what kind of weight did the low carb diet lose? So you can lose fat, or you can lose fat free mass, which would be muscle and water. And so they showed that actually the low carb diet lost more muscle and water or fat free mass, and the low fat diet actually lost more fat. And that sort of makes sense because the low carb diet is a high fat diet, especially ketogenic diets are high fat, low protein, and very, very low carbs. They also looked at immune system changes in the short period and showed that there were clear changes compared to baseline. But things that they noticed was that maybe the ketogenic diet had a little bit more upregulation of maybe the adaptive immune system, whereas the vegan diet had a significant upregulation of the innate immune system and pathways with antiviral immunity, such as natural killer cells. So really some changes in the immune system, and specifically with the even the ketogenic versus vegan diet, you can see that the natural killer cells and activated T helper were increased in the vegan diet. And that's more on the RNA sequencing molecular level, but how does that translate to clinical outcomes with immune infections or risk? So COVID was a good way to study this, and there were 2 or 3 studies done on dietary patterns and COVID risk. You may have seen them already, but plant-based diets, like they've surveyed 6 healthcare workers from 6 countries, and what they showed was that doctors or healthcare workers on plant-based diets or pescatarian diets actually had lower odds of moderate to severe COVID compared to those on low carb or high protein diets, suggesting similar to what we're seeing in the prior study, that there is some antiviral effects of a plant-based diet too. Here, there is also another study looking again at diet and COVID-19 and showed pretty much the same thing, but they looked at it with a different method. They used what's called the Healthy Plant-Based Diet Index. So calculated the score for each person based on how much of their diet was healthy plant-based foods. And you can see that those that had the higher score were associated with lower risk and severity of COVID. And this was irrespective of socioeconomic status as well. So we just talked about how dietary patterns, obesity, diabetes, the microbiome, and immune system can play a role in cancer. I think thinking about how do we study this in interventional trials and think about it in the prevention setting, treatment, and survivorship. So in prevention, I think it's possible to think about this as the backbone of trying to prevent true cancer development or secondary cancers. In the treatment setting, when patients are on immune therapies especially, can there be a synergy with dietary patterns and immune therapies to improve outcomes? And then in the survivorship setting, is it possible that patients actually may live longer or have better quality of life if they have better lifestyle changes? One of the first papers in this topic or field that I worked on was looking at a review on plant-based diets and ketogenic diets. And the reason I got thinking about this was, as I was designing my pilot study, I wanted to see what other trials are happening in the space of cancer and diet. And what surprised me was that there were so many ketogenic diet trials and almost very few plant-based diet trials. But when you look at epidemiologic studies, all the data points towards more plant-based diet trials. So what was seen in epi studies and what was being done in interventional studies had a pretty big disconnect or mismatch. And with that, I just wanted to also think about, like, because these are very opposing diets, so what are mechanisms that they both may have anti-cancer effects? So what you can see here is that both diets would have an improvement in weight, as I showed you in prior slides, improvement in insulin, inflammation. However, plant-based diets also have fiber and flavonoids, which are very specific to plant foods, which have short-chain fatty acids like butyrate that can have anti-cancer, anti-inflammatory effects, and also transit time in the colon, which can affect outcomes. And butyrate would be considered a metabolite with anti-cancer, anti-inflammatory effects. And in parallel to that, I would say in a ketogenic diet, you can have the ketone bodies, which have anti-cancer, anti-inflammatory effects. But the challenges with ketogenic diet that I see for cancer and in general is a couple things. One is it's not so physiologic, so very, very hard for people to do it long term. And often they think they're doing ketogenic diets, but they're really doing low carb and they're not getting this benefit, because to get this benefit, you really need to be in such low carbohydrate state that there is ketosis forming. Second thing is that I showed you that maybe patients with ketogenic diets may be losing muscle mass, and we don't want that in cancer patients, especially with cachexia issues. So I think that any study that's looking at a ketogenic diet should be looking at body composition too. And then thirdly is there's a lot of data which many of you will be familiar with around cardiovascular risk factors with these really high fat diets and risk of plaque formation and lipid cholesterol issues, which also, if it's a long-term dietary change, that can be an issue. But I think if it was done for a very short period, defined because maybe it has mechanisms around cancer, that's a different thing. And so when like I told you on clinicaltrials.gov, there were 46 ketogenic diet trials in 2022 and only 8 plant-based diet trials. And you can see the ketogenic diet trials, many of them are terminated or unknown status because they're very, very hard to accrue to, and many have to close early because of that. Whereas I don't think we see that with plant-based diet trials, and many of the trials we're doing just now are accruing quite quickly. With calorie restriction, you can also see a reduction in IGF-1 or insulin-like growth factor, similar to what you would see in a plant-based diet, but you also can see reduction in inflammation and immune changes too. So calorie restriction could have some of those benefits, but I think compared to changing diet quality, just changing amount of calorie restriction may not have as much of a benefit. So moving on to our pilot nutrivention trial. So this was an interventional study that we did for cancer in the pre-cancer space. So monoclonal gammopathy and smoldering myeloma, these are pre-cancer states that in some patients over time may progress to the cancer multiple myeloma. When we see these patients in clinic, we just tell them there's nothing to do, come back in every 3 to 6 months or every year. We will check the protein levels and see if things are progressing. If they progress, then we treat them. But if they are in these early stages, we just monitor. So it can be quite unnerving for patients. And we know that as the disease progresses, there's more genomic changes and also immune function changes. And these immune function changes can be affected by all of these things that I just talked to you about. So is it possible that we can tilt the scale for myeloma development with improving these risk factors and outcomes? So that was the hypothesis for the nutrivention trial, where we provided 12 weeks of high fiber plant-based meals We provided 12 meals per week for 12 weeks. We shipped them to patients, as you can see, and we only enrolled patients with an elevated BMI because of the data around increased risk of progression with that. The study was designed for a feasibility endpoint, and what you can see is that baseline dietary adherence improved from the baseline of 20% unprocessed plant food intake to 92% at the end of 12 weeks while on study, while they're getting food. And then after they stopped getting the food and they were getting some coaching up to 24 weeks and nothing up to 52 weeks, you can still see that they're much better than where they started, at about 60% of their calories coming from unprocessed plant foods. The patients lost about 7% weight, but you can see that weight loss maintained even 1 year later, suggesting that the changes they maintained. You can also see quality of life improve. So this is the overall score for global health status. And you may ask, how difficult was it for patients to do? And we had 15 patients respond to this, and you can see that actually none of them said it was difficult, which was surprising, but it's encouraging to say that patients actually really, for the most part, enjoyed it and felt like they learned a lot. What you can see is that cardiovascular symptoms improved by the green bars. You can also see depression and anxiety for some patients improved, energy improved, sleep improved, and also GI symptoms got better for some. And of course, many did not have these symptoms, as you can see in gray. So if they didn't have it, we can't really test whether it improved. That's where it's not applicable. 4 participants were able to stop medications, and this might be interesting to all of you all, but one patient was on antidepressants, so bupropion for mood, and was able to stop that while on the intervention, and for many years after has been off. And so these patients were able to save monthly prescriptions as well. When we look at trajectory of disease, so in this precancer state of MGUS and smoldering myeloma, what we follow is a protein in the blood called an M spike. And this M spike over time, it's like, think about like PSA, which is the elevation in PSA tells you somewhat what the tumor burden may be. So the M spike also gives us a somewhat correlation to that. Many patients on the study were newly diagnosed, so we didn't have pre-intervention data, but there were patients also who had very tiny amounts of disease. So it's so tiny that it's hard to look at changes in that. But there were 2 patients who very clearly had rising disease before going on the study for 5 years. And what you can see here is on the study, there was some slowing down of the progression, it seems like, and we calculated p-values which were significant. So we think that maybe these 2 patients had an effect of the dietary intervention in slowing progression of the cancer, of the precancer state. When we look at biomarkers of progression too, we know that insulin levels, we would want them to be lower. We did see an improvement in insulin despite them eating almost the same number of carbohydrates. It's just complex carbohydrates and avoiding refined carbohydrates. Gut microbiome diversity. So you probably are familiar with this concept, but higher diversity, think about it like a rainforest, and we want it to be more diverse usually, and that's usually a good thing. We were able to show that diversity improved with the intervention, and it also continued to remain high a year out as well, which is encouraging. Butyrate producers improved as well. When we look at inflammation, we saw the C-reactive protein, so a marker of inflammation, was elevated in 7 patients before they went on the study. And this actually dropped by 50%, so it normalized for most patients that it was elevated before going on the study. Neutrophil count also went down a bit, suggesting less inflammation. And if we look at immune subsets or how the immune system's changing, we saw an increase in classical monocytes, which are considered anti-inflammatory, and a reduction in non-classical monocytes. and few other immune changes, as you can see, suggesting again that the immune system is shifting as well. What we were able to do, which is probably very unique in this study compared to any other dietary study, is that we had 13 patients with paired bone marrow samples at baseline and 1 year later, because bone marrow biopsies are done to assess disease burden. But you can see we looked at the immune system changes in the bone marrow, and we can see, similar as the monocytes in the blood, there are similar changes in the bone marrow too. But also granulocyte, monocyte progenitors, these are basically the precursor to the neutrophils in the blood. And those levels increased after the intervention, whereas in the blood, the neutrophils went down, suggesting that there's less need for the neutrophils to circulate, but there's more immune potential in the bone marrow of the precursor cells. This is an immune interaction map. So if you look in the blue circle, these are all myeloid cells, and it includes the monocytes. The gray lines tell you how they are all interacting or talking with each other at baseline. And you can see most of the gray lines from the blue circle are interacting with the exhausted T cells at baseline. And then at the end of the intervention, or the green lines, you can see that most of them are interacting with the cytotoxic and the natural killer cells, suggesting that there is a shift in the immune function and maybe better anti-tumor immunity. This was one of the patients on the study, before the study and after. This patient was on insulin for 30 years and was able to stop and really felt better too, and felt like he had more energy. So I do think that some patients especially had quite dramatic changes. When we look at the same effects in mice, so this was in collaboration with Dr. Matteo Bellone in Italy, and in his lab, mice with smoldering myeloma were put on either a high fiber diet or a standard diet. And you can see that the mice on the high fiber diet, half of them never progressed to myeloma at the end of the experiment, whereas the mice on the standard diet, all of them progressed at the end of the experiment. We do see, though, that the mice with a high fiber diet did eat slightly less calories and had slight decrease in weight, but that increased with time. We did further experiments and do not think that this effect is only due to weight loss, but this is an effect of the diet quality. We are doing studies that are currently enrolling in this population with MGUS and smoldering myeloma patients. This study is a decentralized trial where it's enrolling nationally. Patients are doing the intervention completely remotely and sending us microbiome samples, which we hopefully will finish enrolling at the end of this year. And then this is a study that's enrolling and very similar to the pilot study I showed you. And this would be patients who are getting diet or curcumin omega-3 supplements or placebo supplements. And we're looking at the effects on MGUS and smoldering myeloma as well. Next is, if we think about diet and the treatment setting, so we talked about prevention. So is it possible that diet with drug could improve outcomes more than just drug alone? And few examples that I want to talk about was, one is that microbiome may actually influence progression. So in this study, the mice with myeloma were given antibiotics to get rid of their baseline microbiome, and then they were given a fecal microbiota transplant from either a myeloma patient or a healthy control. And they showed that the mice who got the microbiome from the myeloma patient actually had faster progression of their myeloma than the ones that got it from the healthy control. No other differences, just the microbiome changing and the tumors progressing faster. They also showed that a pathogenic bacteria like Klebsiella has much faster progression than a butyrate producer like Clostridium butyricum. And then they also showed with ammonia and urea that there can be progression, so suggesting that nitrogen recycling bacteria may worsen progression. Studies have looked at short chain fatty acids with disease, and newly diagnosed myeloma, so the cancer state, actually have lower butyrate compared to MGUS and smoldering myeloma, the pre-cancer states, suggesting again that there's a difference in the short chain fatty acids. And in the cancer patients that have a response, there is also better, higher butyrate levels. We're opening a study later this year in newly diagnosed patients to look at the effect of diet on diet while they're simultaneously getting chemotherapy as well, for myeloma patients. And then when we think about leukemia, this study looked at calorie restriction. And in newly diagnosed, this is an adolescent young adults, so patients between 10 and 21 years of age, so young patients, but they made them eat healthier and also exercise with some calorie deficit for 1 month during their chemotherapy. And they showed that actually they had better insulin resistance markers like adiponectin leptin ratio, but also a reduction in a better response. So MRD positivity is that there's still cancer present, and there was less MRD positivity in the study patients than a historical control, suggesting that the disease may have responded better to treatment. Dietary fiber and Mediterranean diet and melanoma, there are 2 studies, both showing that patients on immune checkpoint drugs, so these are drugs like nivolumab, which are used mainly in melanoma, but also many other cancers, that dietary fiber, there is quite a bit of data now surrounding this, that patients who are eating fiber-rich diets actually have better responses. And in this study, they showed that if they're eating enough dietary fiber, but also having probiotics, they may actually have not as good a response as if they're having the dietary fiber without the probiotics, because probiotics may affect the microbiome by reducing diversity or having very few strains. So I think it's important to have a healthy microbiome through dietary changes. The fasting mimicking diet is a study where they did like 5 days of a plant-based, very low calorie diet. And then the rest of the cycle of chemotherapy, they could do whatever food they wanted. And they included all different kinds of cancers. And they showed, of course, that, after doing those 5 days of that fasting, there's an improvement in insulin, IGF-1, ketones, things like that. But I think, and they also showed that there are immune changes. I think, though, that doing those 5 days are really sometimes challenging for somebody to eat such low calories for 5 days, especially when on treatment. When we showed in our study, it's possible to get some of those benefits without fully doing the fasting, but then we are expecting the changes in their diet more long term. I'll skip this one, but it's basically showing that when cancer patients, we try to restrict diet and say you can't eat fresh fruit and vegetable, there is worse quality of life, but no difference in infection risk. So it's more important to actually let patients eat the fresh fruit and vegetables, but just wash it well and make sure they're eating it from a good source or place which is hygienic, than not allowing that. And then lastly, and just thinking about the cancer survivorship space, can lifestyle changes help? We talked about diversity briefly, and I showed you in our Nutrivention trial that we were able to improve diversity. But what I want to show you here is a study that looked at diversity and outcomes like progression-free and overall survival, and showed that patients who had higher microbiome diversity actually lived longer. So if we are able to change a microbiome, could we help patients live longer? That has not really been done yet, like an interventional study where we change diversity and then we see if they live longer, but there's a lot of correlations already showing this. And we have one more study we published showing that patients who had high diversity, high butyrate producers, and high butyrate concentrations in their stool or higher than the others were more likely to be sustained MRD negative. And dietary factors such as healthier proteins and flavonoids, which are found in plant foods, were associated with these butyrate and sustained MRD negativity. So we think that diet's affecting the microbiome, and through these immune changes affecting myeloma control. We have finished this study enrolling, and hopefully at the end of this year, early next year, we should have some results around that. There is a sub-study for diet included in this study, so we should have some data on patients on lenalidomide and daratumumab. So with that, I think, dietary changes which are fiber rich can have effects on the on body mass index, insulin resistance, inflammation, the microbiome, short chain fatty acids, and maybe anti-cancer, like cancer cells too. And I think just knowing that sources of dietary fiber really only come from unprocessed plant foods. So making sure that patients are getting enough dietary fiber. And then when I do these talks, often people may ask, like, what do you mean by a plant-based diet or a high fiber diet? I want to be clear that a vegan diet doesn't tell you anything about the health benefits or not. And a vegan diet is basically a diet that is for ethical and environmental reasons, and there would be zero animal products. It can be very healthy, but it doesn't have to be if somebody's eating Oreos and French fries. A vegetarian diet also, many people do this for ethical or religious reasons, but it doesn't have to be healthy, and it can be very unhealthy if they're eating a lot of fried foods and mainly focusing on processed or dairy-rich and eggs-rich food, where then they're really not getting enough fiber either. What we're talking about is a high fiber plant-based diet that's really focused for the majority of calories coming from plant foods. And you can see that in this plate too, which is from the Canadian Food Guide, half the plate with fruit, vegetables, a quarter carbohydrates, and the protein is mostly plant protein. So I think, when talking to patients, I think if they can get 80 to 90% of their calories from high fiber plant foods, it is possible to start seeing the benefits. And these are just some practical tips to consider. I think sometimes one big skepticism is that, they may be living in a food desert and they don't have access. But remember, beans, lentils, legumes are things that can be found in pantry, and also whole grains, as well as cans. And frozen fruits and vegetable bags are as healthy, if not more, because they are picked right when it's fresh and have all the vitamins and minerals. So it is possible, at least in part, to be doing this wherever a person is. Yes, it may need some more planning, but it's not impossible. And eating healthy doesn't have to be boring. It just needs some planning. And we're not talking about salads all the time. We're talking about whatever the person likes to eat, whether it's a burger or it's pasta, but in a healthier version of it. And this is the paper with Gia that we wrote in JAMA, which basically was to bring attention to personal and planetary health and how this is so very much connected in our food system. And so if we look at just one serving of meat, that's about 1,200 grams per CO2 equivalents per serving. And beans is just less than 1. So there's a very significant greenhouse gas emission difference between just one serving of different protein-rich foods. And so as medical professionals, we have the opportunity to positively influence patients, family members, the population, and the planet as we help patients eat more fiber-rich foods and help them improve their personal health. You are indirectly helping planetary health too, because that reduces greenhouse gas emissions as well. So with that, I'd like to thank you all for staying on and listening. And doing science like this really takes a strong team, and it's team science and a village. I would like to thank the Nutrivention trial participants and all our funders as well. And thank you for listening.